We'll be discussing out-of-office blood pressure checks. My name is Dr. Godsent Isiguzo. By way of introduction, office blood pressure measurement has been standard of care in diagnosing and managing hypertension. However, results obtained from these measurements may be compounded by several factors and are limited in time and place. To improve the effects of detection and control of hypertension in general population, organizations from different countries have come out with different guidelines proposing some recommendations. Use of out-of-office blood pressure measurement is one of such recommendations, which implies checks in blood pressure done in places not in the hospital setting. One such measurement device is the ambulatory blood pressure measurement, which is actually a portable device that the patient wears and goes home, and depending on the setting, BP is automatically measured over a period of 24 hours. Usually we put it in the non-dominant arm so that the patient can do other things as the measurement goes on. Another one is the home blood pressure measurement, which is getting popularity in almost every home now. In 2017, the American College of Cardiology and the American Heart Association guideline stated that devices such as the ones we mentioned now should be used to confirm hypertension diagnosis and to titrate blood pressure lowering medications. The European Society of Cardiology followed suit a year later to make the same recommendation. So also the Chinese guideline, which in addition stated that this use of out-of-office blood pressure tools should be used to diagnose white coat hypertension and mask hypertension. And one may ask, what is this? So to remind us again, white coat hypertension is actually what we see when patient comes to the hospital and your blood pressure are checked, and then it's usually high. And they complain that at home they check their blood pressures and it's usually normal. And the term white coat used to represent the symbol in the hospital. So just a mere thinking of coming to the hospital can actually lead to a rise in blood pressure in a patient whose blood pressure ordinarily is normal at home. While mass hypertension refers to patients who come to the hospital and their blood pressure checks are normal, meanwhile they have evidence of hypertension, and then when they check their blood pressure at home or in other places, it's usually very high. Ambulatory blood pressure measurement and self-measurement of the blood pressure, therefore, were developed as tools to provide more standardized and reliable estimation of the true blood pressure of a patient and to stage cardiovascular risk. Now, we need to remind ourselves of the devices used in measuring blood pressure. We are all familiar with the mercury in glass sphygmomanometer. We also know the automated measuring devices are actually getting popularity now, and we'll have our Android blood pressure measuring instruments. But let's go a step backward to remind ourselves of the correct ways to measure blood pressure of a patient. So when a patient comes to measure blood pressure, the patient shouldn't have eaten the last 30 minutes or smoked. The patient should have emptied the bladder and do the measurement. The patient is supposed to be talking. They are supposed to rest on the table at the same level with the chest and the measuring instrument. The cuff should be applied on the bare skin, the back should be supported, and the patient's legs should be firm on the ground and not crossed. Now, we need to identify if we are using the mercury in glass BP machine, we're supposed to check for the radial pulsation, and as we inflate our cuff, we'll note where the radial pulse disappears. That's a rough estimate of where study blood pressure is. The normal teaching is to raise the mercury column by up to 10 to 15 millimeter mercury on top of where we notice the disappearance of the radial pulse, and then gradually deflect. We're also supposed to identify the brachial artery when we are measuring the blood. So tie your blood pressure measuring tool on the arm of the patient. You notice where the brachial pulsation is, because that's where the state will be placed to listen to the protocol sounds. It's recommended that patients is relaxed, and then ensure that tight fitting clothes are not worn around the arm, and then the cuff must be at the same level with the heart, and then if the arm circumference is 133 millimeter, you might need to get a larger cuff. Then you place the stethoscope, as we said, diaphragm will stop on top of the brachial artery. The column of mercury must be vertical and should be dropped 2 to 3 millimeter per second as you deflect. Now, if you check the blood pressure of the patient in the office and it's not elevated, however, the out of office blood pressure is elevated, so the patient qualifies into the class of mass hypertension. If, however, you check the blood pressure in the office is high, and you check the out of office blood pressure is still high, such a patient qualifies as sustained hypertension. While if the out of office is low, it's not high, then that's widespread hypertension. So we have three phenotypes here. In either of the three, lifestyle modification is essential. If he has sustained hypertension, drug therapy. If he has widespread hypertension, drug therapy for high risk patients. If he has mass hypertension, then drug therapy. For the three, we are encouraged to do periodic out of office blood pressure monitoring. While doing this, if you have repeatedly finding of abnormal circadian BP patterns or morning surge, which defines sudden rise in blood pressure in the morning, or high BP variability, this defines measure by measure changes in blood pressure, or patient complaints of hypotension. Such an individual needs drug modification or other treatments to control the blood pressure. Now, from our discussion so far, we have either out of office measurement or in office measurement. In office measurement could be conventional blood pressure measurement that we do in our clinics, or automated measurement that patients on admission in the ward have on them. Either of these clinic effect is synonymous. While in out of office blood pressure measurement, you have either observer measured by relatives or by caregivers, or self-measured. These two don't have any clinical effect. However, ambulatory blood pressure stretches between the two because patients that will be on ABP measurements will be hung in the hospital most times, and they now go home with it, and the measurements are taken specially. Now, we have either mass hypertension, which defines blood pressure rise in the hospital and normal at home, or we have sustained hypertension, which is blood pressure both high in the hospital and at home, or we have white coat effect, where blood pressure is high in the hospital but normal at home, or we have normal in both ways. Now, if we look at this closely, this is defined based on the cutoff for ambulatory blood pressure measurement or home blood pressure measurement. 135/85 day measurement defines hypertension, while night of 120/70 and above defines hypertension. While, of course, we know 140/90 and above defines hypertension in the office. The numbers in parentheses refer to the American cutoffs, but we are basing our discussion on World Health Organization cutoff. So, definition once again, 135/85 and above in day 24-hour day ABP measurement or home blood pressure measurement, that is hypertension. If you find out in a patient that blood pressure is normal in the hospital, then that such a patient has mass hypertension. If you find in a patient that the blood pressure is high in the hospital, then that's sustained hypertension. However, if you find cutoff of 135/85 lower than that in a patient that has in the hospital a blood pressure higher than 140/90, then we are discussing white coat hypertension. Now, what is the general characteristics of these three measurement modalities? When you look at popularity of device, of course, we can agree that office blood pressure measurement is in wide use, while home blood pressure measurement is becoming popular with time. But ambulatory blood pressure measurement is still not popular, especially in low and middle income countries. When you look at reproducibility, home blood pressure measurement is more reproducible. And when we look at BP variability, which talks about the changes with each measurement, for office blood pressure measurements, when the patient presents in the hospital, that you find variability. That means it's patient visit variability. While for home blood pressure measurement, as they do it daily, you have changes. And then for ABP measurement, hourly variability is same. What of nocturnal BP, which is actually our blood pressure when we sleep? Only a blood pressure measurement can actually give us information on that. While for morning surge, we can have that information either with ambulatory blood pressure measurement or with home blood pressure measurement if we're able to check it on waking up in the morning. For white coat effect, of course, the hospital measurement will give us that information. Now, usually out of office blood pressure measurement is lower than office blood pressure measurement in assessing blood pressure. And of course, this difference is more pronounced as office blood pressure increases. Out of office blood pressure measurement gives us a large number of BP records from which to make our inferences. And out of office blood pressure measurement is used in doing surveys or response to treatment in discussing white coat effect and mass hypertension, and to assess and confirm patients' compliance with medications. Now, what actually is involved in ambulatory blood pressure measurement? When we do ABP, patient goes home with a portable BP device set up to record blood pressure over 24-hour period, usually put on non-dominant arm for obvious reasons. In clinical practice, we usually set this measurement to record either every 15 minutes or 30 minutes during the day and every 1 hour during the night, or some make it 30 minutes at night. If the machine is able to record 70% of blood pressure within the 24-hour period, that can be used to take decisions. Now, it's more reproducible if ABP is allowed to last up to 24 hours. And of course, we will discuss the cutoff for making diagnosis. What other information can we infer from the ambulatory blood pressure measurement? Usually, because we're measuring blood pressure at night and during the day, we're going to have a difference between the nighttime and blood pressure measurement over time. And this difference can be used to take decisions. Usually, what will you call day and night depends on when the patient sleeps. But in average, it's set between 6 a.m. and 10 p.m. And then from 12 midnight to 6 a.m. defines night record. Now, the night to day ratio can be used to define dipping. Dipping here refers to the fall in blood pressure as we sleep. Usually, this nighttime dipping has implications for cardiovascular morbidity and mortality. A patient that has no dipping, the ratio for night over day will be more than 1. For patient with mild dipping, it will fall between 9 and 1. For dipping patients, it will be between 0.8 and 0.9. Other information you can get from ambulatory blood pressure will include the variability hour by hour, the morning surge, which refers to the sudden rise in blood pressure on waking up in the morning, which has been shown to correlate with such events like stroke. Now, studies have shown that patients that have nighttime blood pressure readings, that it's more a better predictor of morbidity and mortality compared to daytime. And then it's also the dipping pattern has implication for cardiovascular events, with patients that have no dipping being said to be at greater risk. What of for prognosis? The ambulatory blood pressure measurement have been shown to correlate more with organ damage in patients, and it's a better predictor of clinical outcomes such as fatal and non-fatal coronary events, stroke in general population in these patients. However, we need to state that in a resource-poor settings, 24-hour ambulatory blood pressure monitoring is not readily available either because of the cost or the instrument, but this is improving over the time. What of home blood pressure measurement? This is becoming available in most homes, and the ideal is to measure the blood pressure every day. But if you can measure 3 to 4 days in a week, that would be nice. Usually, you should measure it 2 to 3 times, 1 to 2 minutes apart. The first reading is usually discarded and use the later reading. Conventionally, the measurement of blood pressure in the office remains the gold standard for screening, for diagnosis, and monitoring for hypertension. Out of office is an important adjunct to office blood pressure. We need to know. Is there a difference between ABP and home blood pressure measurement? Yes, they're different, but which one you choose depends on the indications, the cost, the ease, and then patient preference. It's advisable that if a patient has a borderline home blood pressure measurement, such a patient should have an ambulatory BP measurement. Home blood pressure usually correlates closely to hypertension-induced organ damage in patients, i.e., left ventricular hypertrophy, than office blood pressure measurement. Some meta-analyses have shown that it also in primary care of patients, it can actually help predict cardiovascular morbidity and mortality compared to office blood pressure measurement. Or ABP and home blood pressure measurement, which one is better? It's a discussion that is difficult to come to conclusion with. However, home blood pressure measurement has been shown to at least as well correlated with organ damage as blood pressure measurement. What are the clinical indications? If you suspect a patient has white coat hypertension, such a patient has grade 1 hypertension in the office, but have no symptoms or no end organ damage, such a patient might need to do ABP. Or if you suspect mass hypertension, a patient that has a normal BP in the office, meanwhile at home the pressure is high, and then you're beginning to see symptoms and you have end organ damage, then such a patient will actually need to do ABP. If you want to identify white coat effect in a patient, or if you're worried about variability, or patient complain of autonomic changes like postural changes, postprandial hypertension or hypotension, or patient with to have eclampsia, the patient require it. And if you want to also have categorical statement about false or true hypertension. Now, what other physical indications you need ABP for? When there's discordance between office and home blood measurement, when you want to assess the dipping pattern, or you suspect your patient might be having structural hypertension, or you want to assess variability. What is general recommendation? Office blood pressure measurement is still recommended for the screening and diagnosis of hypertension. It's recommended that this should be done at least 2 BP measurements per visit, and at least 2 visits to make a diagnosis. Out of office blood pressure measurements should be considered to confirm diagnosis, to identify the type of hypertension the patient has, to detect hypertensive episodes, and to maximize prediction of cardiovascular risk. We should actually also use it to monitor our patient depending on indications and then cost if appropriate, and also what patient prefers is important in making this decision. Generally, in accordance with international standards, there has been a push for automated validated instruments to be used for measuring BP. So you need to find out what instruments are validated in your environment so you can use them. In the African context, these machines and monitors are not universally available, but efforts are on to improve in this, and they should be used where they are available. Thank you.